Assalamu alaikum. Darwin Clinical Consultation Day. First scenario, Mrs. Mary, 55 years old, referred with chronic ulcers on her fingertips, please, which are not healing. Please take history, examine the patient, and address her concerns. So we can start in a while after recording or after timer sharing. Ready?
Yes, ready.
Yeah, here you go.
Hi, hello.
Hello.
My name is Dr. Ayola. I'm not with doctors here in the clinic. Can I confirm you are Mrs. Mary, 55 years?
Yes, doctor.
All right. You are welcome to the clinic, Mrs. Mary. I understand that you've been having some concern about your fingers. Is that right?
Yes, doctor. That is right.
Okay, good. So we are here to discuss about this and to be able to arrive at a diagnosis and treatment plan. Is that okay, Mrs. Mary?
Okay, doctor.
All right. Could you tell me more about this and problem?
Yes, doctor. For the last long time, I have this ulcers on my tip of my fingers, and I can't remember anything to cause them. Even any small cut on my finger took 3 or more weeks to settle, even with treatment. I don't know why.
Oh, I'm sorry to hear about this, Mrs. Murray. Could you tell me which of your fingers are you having this ulcer?
Now it is my middle finger, but all my fingers, the problem from before in all my fingers.
Okay, it's on all your fingers. Okay.
Hand. Yes.
And how long ago have you been having this?
This long time, doctor, but for the last 5 to 6 weeks, I have increasing pain in my hands.
Okay, can I have a look at this ulcer?
Yes, doctor.
Okay.
There is ulcers on the fingers, some deformities, and it's shiny skin.
Okay, all right. Thank you, Mrs. Murray. And have you ever had this before?
No.
Okay, you were about to. Okay.
Now increasing.
Okay, and how long ago have you had it exactly?
Maybe 4 years now.
4 years. Does it comes and goes?
Yes, it is constant, but now increasing.
Okay, is there anything that you think make this ulcer worse?
I'm not sure, doctor, but now there is severe pain also.
Oh, I'm so sorry to hear about that. And the pain is something that recently, when did the pain started?
6 weeks ago.
6 weeks ago. Okay, is there anything that make the pain worse?
I think in cold weather it become very painful more.
In what, please?
Cold weather.
Cold weather, okay. Is there anything that relieve you of this pain?
No, I think if I just warm my hands, it become less painful.
Okay. Have you noticed any change in color in your hand since it started?
Yes, doctor. There is change in color.
Okay, could you tell me more about this?
I noticed that my fingers become white, sometimes blue, sometimes red.
Okay. And do you have similar ulcers in any other part of your body?
Also in my toes.
In your toes. Okay. Is it similar to the one in your hand?
Yes.
Is it painful as well?
Yes.
Okay. You told me that your skin are also shiny. Is it just in one in the hand or all over your body?
Both hands.
Both, and is not involved. All other body skin are there's no similar changes in your skin in any other part of your body.
It is mainly on my hands.
Okay. Have you got any rashes on your body?
I feel like a small red rash sometimes.
Where do you have these rashes?
All body, face, and hands.
Okay. And any fever?
No fever.
Any lumps and bumps?
No.
Okay. Have you noticed that you've been getting tired easily these days?
Yes, I feel tired.
Okay. Okay. Tell me more about this tiredness. Is it associated with any time of the day?
No, all the
Okay.
day.
All the day. And is there anything that make it worse?
No, it is not specific. When I do exercise, sometimes I feel tired.
Okay. All right.
It's not bothering me, doctor.
No. Okay. All right. Thank you for telling me that. Is quite useful. Okay. Do you have any issue with your sight, Mrs. Murray?
Of what?
Your sight, your vision. Any issue with your vision?
No.
Okay. Any headache?
Headache? No.
Yeah. Okay. Any difficulty with swallowing?
Yes, doctor. I have difficulty swallowing.
When did that start?
This is few years ago.
Few years ago. Okay. And that must have been very discomforting for you. Is this only to could you tell me about this cortisol? Is it both to solid and liquid?
It is mainly to the solid. For that, doctor, I seek medical advice.
Mm-hmm.
They did for me endoscopy,
Mm.
and they said it is normal. So
It
I
is
do
what?
not go further with test.
It said it is what?
Camera test is okay, normal.
Okay, all right, all right. And since then, it's been getting worse. Has it been getting
No,
worse?
it is the same.
It is the same.
Whenever I eat solid food, I feel this difficult swallowing. So
Oh.
now I'm avoiding that. I'm trying to take water more and.
Oh, that must be challenging for you, Mrs. Murray. Have you
Yes.
noticed any weight loss?
No.
No weight. Any tummy pain?
No.
Any change in your bowel?
No.
What about vomiting? Are you vomiting?
No.
Any illness of your eyes?
No.
Any itchy skin? Is your body itchy?
No.
Have you got joint pain?
No.
Okay. Are you coughing, Mrs. Murray?
No.
Any shortness of breath?
No.
Okay. Have you noticed that your heart is racing?
No.
Okay, all right. Tell me, any concern about your waterworks?
No.
Okay, and just a second. Okay, have you noticed any lumps and bumps in your body? I think maybe just
No, doctor. No.
not okay. Okay, just a little bit about your medical history. Have you managed, Mrs. Murray? Have you managed for any medical condition?
Yes, also when I visit the GP, he told me I have high blood pressure and gave me medication for that.
Okay, and how is the control like?
Yes, now it is controlled.
Okay, what medication are you having, Mrs. Murray?
Yes, only one medication.
Okay, do you know the name?
I think Ramipre or something like that.
Okay, and how long have you been? How long ago was this hypertension diagnosed?
I think 1 year ago.
Okay, all right. And have you noticed any swelling on your body? Any swelling in your body?
No.
No swelling. Okay, thank you for that. Apart from hypertension, are you planning for any other medical condition?
Yes, I'm taking lipid lowering medication.
Lipid, you
I
said?
have raised cholesterol.
High cholesterol. Oh, there. And how is the control? How is that? Is that well managed?
Yes, it is controlled.
Oh, it's controlled. Okay, all right. And are you any and what medication are you having for that?
Atorvastatin.
Versatin.
Or-
Okay.
Yes.
All right. And apart from this cholesterol and blood pressure, any other medical condition?
No.
Are you on any other medication, including over-the-counter drugs?
No.
Okay. All right. And are you on? Do you have any allergy?
No.
Okay. Mrs. Mary, can you tell me about your period? Sorry, this might sound intrusive. Your period. How is your period like?
It is regular. No problem with that.
No problem with that. Okay. All right. Are you on any contraceptive?
No.
No contraceptive. Okay. And how is this? Do you smoke, Mrs. Murray?
Yes, I was smoked for 40 years before, but I stopped 3 months ago, as my GP suggested that.
Oh, well done. That's applaudable. Well done. And do you take alcohol?
No.
No alcohol. Okay. And do you have any allergy, Mrs. Murray?
Allergy? No.
And what do you do for a job?
Recently, I changed my job. I'm working in an ice cream shop.
Okay. What were you doing before the ice? Okay, you were working the ice cream job.
Yes.
Okay. Do you use any form of heavy machine, like vibrating tools at any?
No.
And why did you change your job from the icing? Why did you change your job?
No, just a social issue because I changed my area where I live to another area, so I changed my job.
And do you think since you changed your job, have you noticed any change in your symptoms?
I don't know, but my symptom increasing now.
Okay, so what are you doing now? What job are you doing now?
In this ice cream shop.
Okay, what were you doing before? Sorry, I think what were you doing before the ice cream shop?
I am a banker.
Bank. Okay, and you don't use any form of every machine then? Vibrating tools? No. Okay.
No,
No. All right. Thank you for that. And who do you live with, Mrs. Murray?
with my husband and my kids.
And are they supportive?
Yes.
All right. Mrs. Murray, have you got any concern today?
Yes, I want to know what can you do to make my ulcers heal? Why
Okay.
I can't swallow solid food?
You said what?
Why I can't swallow solid food? What's wrong if my endoscopy was normal?
Okay. All right. Thank you for speaking with me. Before I go ahead to discuss about your concern, is it all right if I examine you to be able to get full um um good more information about your condition? Is that all right?
Yes, sure, doctor.
All right. Good. So I want to check the all physical examination, check for pallor, check the temperature, and then check the blood pressure of this patient, which is on
Mm-hmm.
okay, and then I will examine the hand for the ulcers. See,
For what?
and the hand
Yes.
for the ulcers, and then I will also examine the foot that you said you have the ulcer, and examine the skin as well to see if basically I'm looking for any form of salt and pepper skin, any change in the color, like hypo mixed with hyperpigmentation on the skin, anything.
Okay. Where you will examine first the hands?
The hand, please, yes, and also checking other part of the body as well.
Okay, in the hands there is tight skin. You should do the test. I will tell you the positive finding.
Okay, all right. So I'm also going to examine the mouth. Any stiffness around the mouth, opening the mouth. Is he able to open the mouth wide?
It is a small
Okay.
mouse.
Okay, all right. And then I would also examine the foot for the ulcer.
There is multiple ulcers on the
Excellent.
foot and on the tip of the fingers, also in the hand.
All right. And then I'm going to check again. All right. Then I also want to do a urine analysis for
Okay.
this young woman, and then examine the chest as well.
For what?
Chest examination.
For what?
I'm
What you will
looking.
do?
I'm looking for. I'll check the tracheal centrality, then the percussion note, and then the expansion of the chest, and then looking for evidence of fibrosis.
Okay.
Okay.
Yes.
All right. So yeah, thank you for speaking with me, Mrs. Murray. From our conversation and the examination findings, well, I'm suspecting that you may have a condition that is called systemic sclerosis. Okay, and It's basically a condition. I know it's a big name, but don't worry about that. It's basically a condition in which there's dysregulation in your immune system, okay, and they start to attack your organs, such as your skin, the blood vessels, and that is why the ulcers in your hand are not healing, okay, because the blood vessels are affected and is affecting blood supply to your hand. And that is why your hand is also changing color. Especially, okay. Could you tell me, did your hand change color when you work in the ice cream shop, Mrs. Mary?
Sorry?
Your hand, has it been changing the color since you started working in the ice cream shop?
Yes, it's increasing now.
Okay.
Increasing.
And that might be the reason why your hand color is changing. Okay. And it might also explain why you are having difficulty in your swallowing, because this causes tightness in some of the your skin, your internal organ, and this may explain why you are having difficulty with swallowing, Mrs. Murray. Okay. All right. Sorry that this might be a serious condition. Okay, and because of the blood pressure that you said you are also recently elevated blood pressure that still recently was discovered by your GP may also be associated with this. So we will want to do further investigation for you to be able to arrive at diagnosis, and that will include special tests, okay, to be able to arrive at this diagnosis, and other routine investigation to include your blood and kidney tests. Okay, we'll also check your lung as well, because it can affect different organs in the body. I'm sorry, this might be a serious condition, Mrs. Murray.
Okay, so any treatment for that?
Yeah, for the treatment, for now, we want to arrive at a diagnosis first. So we'll look for until when this result comes back, and they will be referring to the multidisciplinary team who will further discuss you, and then have a treatment plan for you as well. And then we can also which we also involve occupational health, okay, for your treatments, Mrs. Murray.
Okay. Time is up. 2 minutes added for the concerns extra.
Okay. Do you have any
Well
other
done, Dr.
concern, Mrs. Murray?
Yeah.
No, thank you.
Okay. Do you want to give her advice?
Yeah. Lifestyle changes. I want to give her advice like wearing of gloves when she's going to the ice cream shop, to her shop.
Perfect.
Keep herself warm.
Perfect. Okay. This is what I need earlier. And instead of giving her the options of investigations, she didn't ask you what you will do. I don't know if she asked about the investigation. Anyway, instead you can give her good advice regarding the main possible cause of her condition, which is ice cream exposure or the cold exposure. So either to change the job or to wear gloves. Okay. Let's start the examiner question. Yeah. Great. Dr. Hanadi.
Okay. Present your positive finding.
Okay. This I just pick and examine this lady. She's 55, who presented with non-healing ulcer in the hand and foot with some skin changes. She also had additional to this, she has difficulty with swallowing. Excuse me. Difficulty with swallowing, and then an examination, there is small mouth opening, putting all the, and also add a history of suggested of renal phenomena. Putting all this together, I'm suspecting that she may have a condition called systemic sclerosis. Is it systemic sclerosis?
Okay. Do you think it is limited or diffuse?
I will say it is limited systemic sclerosis.
Okay. Based on what?
Based on the features of the skin changes, the renal phenomenon, the esophagitis. Apart from this, I also want to look out for evidence of telangiectasia as well in this woman. So I will suggesting that it could possibly be a limited systemic sclerosis.
Okay, what is your differential diagnosis?
The differential diagnosis will include primary renal phenomenon. I also think a possibility of a peripheral neuropathy. That's the peripheral neuropathy, and then also systemic diffuse systemic sclerosis can also be a possible differential in this woman.
Okay,
Yeah.
could it be mixed connective tissue disease?
Yes, possibly. Yes, it can be a mixed connective tissue disease.
So, how you will manage this patient?
For this patient, I want to do routine investigations such as the full blood count, particularly the kidney function test. I also want to do specific investigation to be able, like autoimmune screening for the HANA, anti-nuclear antibody, and specific antibody check for limited systemic sclerosis. That would be anti-scleroderma 70. I also want to do other ESR and anticentromen as well. Then I also want to do other inflammatory markers like ESR and the ESR and other ESR. Then in the then other further investigations such as chest X-ray to look at the complications of systemic sclerosis.
Okay. Regarding Raynaud's and the
Is that what?
presentation? Regarding the presentation Raynaud's, any test to do?
Okay.
Okay, how you will treat the patient?
For the treatment, I would want to commence this young woman on steroids, and then also consider some disease-modifying steroid-sparing agents.
Okay, thank you.
Thank you. Thank you.
Well done.
Thank you.
Okay, 1 minute still
Still?
missing. Yeah, we have 1 minute left.
Okay, for the treatment of
yes.
okay,
Continue.
for the treatment of Raynaud's, how you treat
treatment of what?
Raynaud's phenomena?
Treatment of phenomenon is different phenomenon. I could could consider lifestyle changes like wearing of gloves, keeping ourselves warm. If this does not work, then I would consider the use of calcium channel blocker.
Yes.
Calcium channel blocker, and then yeah.
Ticagrelor 90 mg 180 oral only once. This is the pharmacy. And Ticagrelor 90 BID. See?
Okay, you're done, Dr. Hanadi?
Yes.
Then,
yeah, okay. Perfect. Let's start the comment. Well done, Dr. Ayula, by the way. You did great in this scenario.
Yes.
Let's start the comment, Dr. Hanadi, then I will comment.
Okay, in the history type, she did analyze the presenting symptom. The background, she had long-standing history of Raynaud's. Recently, the pain increasing with this ulcers. Then a history of difficulty swallowing and history of high blood pressure. Okay, you ask from all this. Just here in the when I said difficult swallowing, you should ask of other symptoms like acidity, acid brush, because also she has.
Okay.
Also, the area is important because of they have
Bacterial overgrowth syndrome.
yes, bacterial overgrowth, yes.
Yeah.
And then other system all involved because it is multi-systemic. For the you will start from the after analysis of the symptoms from the GI. You ask about the acidity and the diarrhea. This is important, but others also dysphagia because the presentation. Then for the renal system is important here because of renal crisis, and for the respiratory or interstitial lung disease in case of diffuse systemic sclerosis. For the others, it could be as complication, for example, hypertension. You can ask from CNS and cardiovascular. Also in the respiratory for pulmonary hypertension. Also in you forget it in the examination. You should examine for that. To palpate for the second heart sound and basal crackles. Not all the pulmonary system because I think the time will not allow you. The most important is the second heart sound, palpation and auscultation, and also basal crackles. And then if we start the examination, طبعا social history is important here. The job, always you find the job, there is issue in the job like this case. And the smoking is also very important. If the patient is a smoker, to stop smoking, you ask about that. Family history, you should, I think you forget to ask family history. Yeah. And you should screen for other connective tissue disease, especially component of mixed connective tissue disease. You should ask from dry eyes, dry mouth, SLE included in the rheumatology system. Also the myositis, muscle pain, you should ask. Female history is important as recurrent miscarriage. You should ask about that. And then on examination, you started from the hand. You should first make sure that I don't have pain now. And the pillow is important so as not to touch the welfare. And you tell me, I will just do gentle examination because it's painful now. You should start with inspection for tightening of the skin. Here, the patient has sclerodactyly, tightening of the skin with smooth, shiny skin. She has flexion deformity. Also, should ask and look for deformity. And telangiectasia, you will find red spots that when you press over it, it will disappear, even in the maybe in the face and others. Then other elements, calcinosis, you should look for, and also ulcers here. You can find also autoamputation of the fingers. Then when you move up, you will do you will ask for blood pressure, very important. And also you can ask from tell the examiner I want to check for pulses, peripheral pulses of in the arm. Then proximal myopathy. Then when you go up the face, you will inspect for tight skin, mouth puckering, pinch nose, and telangiectasia also. Then go down for the chest examination, as we said, pulmonary palpable second heart sound, pulmonary hypertension, and basal crackles. Then lower limb edema. I think this is all. I don't know if I forget something or.
Yeah, perfect, Dr. Hamid. You cover, I think, most of the manifestation of mixed connective tissue disease, particularly in this scenario, systemic sclerosis and related phenomena. The skin rash only, I don't know if you mentioned. So either in the
Yes, in
history,
form of
skin rash.
telangiectasia. Here, yes,
Yeah, in the hand, yes, telangiectasia. In the face, skin rash to some
telangiectasia or
exposed area, or
yes
telangiectasia
for
for
yes,
SLE.
yes
Yeah.
for differential. Yes,
Heliotrope sign and heliotrope rash, don't forget, and shower for polymyositis, dermatomyositis and polymyositis,
yes,
particularly dermatomyositis. Muscle pain. I wrote in the chat box just in order to remember the missing things. So, Dr. Ayula, you spend 3 minutes analyzing the complaint. That's why you didn't have good time to do the full examination. But I agree for the questions, but try to make it more and more fast and focused question. Your problem here is ulcers. So when exactly onset, course, duration, what increase, what decrease, timing, any particular timing, and if you want to ask about the occupational, as you ask later on, is it related to vibration tools? Is it related to the cold? All these questions are good, okay, to ask, but try to finish up quickly this question because you have a lot of other system affection. So the complaint here we already analyzed. Now we will go to the relevant system. The rheumatology system is one of the most complicated system in basis. Why? You have a lot of system could be affected. Let's imagine on top of them, which is called mixed connective tissue disease. So you might have all the disease in one condition, which is mixed connective tissue disease. Okay, how to figure out the important manifestation either by systemic review or by specific question for each system. So in this scenario, before going inside the station, you have complaint which is very conclusive for a disease you might know even from outside, right? Agree with this? Yeah, skin ulcer, 90% Raynaud phenomena or systemic sclerosis. The other cause may be Berger disease related to the smoker, peripheral vascular disease, or it could be one of the mixed connective tissue finding as Raynaud phenomena. Clear? So this is your differential from outside. You can write it, and while you are taking history, you will try to find out what other possible association. Let's start the relevant system here analysis. What is the most important question to start with? You have musculoskeletal question now. What are the musculoskeletal question you know? Rheumatology. You didn't ask, by the way, this question, Dr. Ayuna.
Yes, I'm with you.
Okay, what about stiffness, joint deformity or stiffness? Did you ask this?
No, I only have some joint pain.
Joint pain, but here is important to ask about the stiffness. What the importance of stiffness in this scenario? Sorry. If the stiffness more than 1 hour early morning, what do you think the case will be?
Rheumatoid arthritis?
Yeah, plus deformity. So I agree to ask about joint pain, but stiffness here also is a clue for rheumatoid arthritis. Stiffness, a deformity, any skin rash to sun exposed area. Now at least you know what you are looking for. These questions are related to the musculoskeletal, skin, muscle, and skin and joint. Skin and muscle and joint, right? If you want to screen for others like systemic sclerosis, you can ask here as a relevant system, you can ask about skin tightness. It's important as well. A change of the color of your skin while exposed to the cold. Is it important? Yes, it is because it's Raynaud. So we have still all questions related to rheumatology. Still, we are in a relevant system. Skin change, tightness, ulcers or soreness. The joint, we ask about, before joint, we can ask about the muscle, any muscle pain, any difficulty of movement while combing your hair. And the last thing is the joint pain, joint stiffness. So you analyze the relevant system. Okay, I'm trying to do every session my approach and to try to apply it on every case. So first analysis of the complaint, then the relevant system. Now the time for constitutional symptoms. Any loss of weight, any change of appetite, right?
Mm-hmm.
Lumbar bumps, night sweat, night body temperature. Maybe you might have this finding as a connective tissue disease. Some patients will have this, or feeling fatigue or dizzy. Okay, you can ask this question. The next is the past medical history, the medical condition. Any medical condition are you complaining or you have any long-standing disease? Yes, I have here hypertension. What medication you are? Enalapril or whatever the medication. Are you compliant? Yes. Did you increase? Did you change? No, it's okay. Other condition I should be aware of. No, doctor, I don't have. Now the time for systemic review. CNS, any headache? You have to ask. Eye, any vision problem is important in this scenario, and add to them dryness of the eyes. You can add specific question for the Sjogren syndrome. Okay.
Mm.
Now you want to ask about thyroid, any thyroid or any intolerance in weather. Before the thyroid and the endocrine, you can ask about weakness and pins and needles. If there is weakness or pins and needles. No, you can ask now the time for endocrine, any interest in weather. No, doctor. The cardiovascular, any chest pain. You might have chest pain, right? Because this is vasculitis. Some patients will have coronary artery disease. Any awareness of heartbeat, palpitation may be associated either due to anemia or whatever the reason. Then the short of breath, here you can find some finding. Patient will have short of breath, dry cough as interstitial lung disease, complicated.
Mm.
Then the GI here, you might have some of the manifestation as you ask, starting from up, difficulty of swallowing. Did you notice your mouth opening is small or narrowed? Any change of your bowel habits? And here it was diarrhea. Any tummy pain?
Mm.
Any acid brush, as Dr. Hanadi said, but it's not common question to ask. Anyway, if you ask, it would be good. Any change of your bowel habits? Diarrhea related to bacteria overgrowth syndrome. Then the next system, genitourinary, any change of the water work, either amount or frothiness. Sometimes we have frothiness as SLE or lupus nephritis. Earlier, we discussed the musculoskeletal or rheumatology system. So now we will go to the family history, any family history of same condition, any travel, the female history with the sexual history you can ask. And don't ask one question for the female. Always remember for female history, 3 Ps. Dr. Ayula, 3 Ps,
Yeah.
pregnancy, periods, and
Periods.
yeah, pregnancy and period and
Pills,
Pills
pregnancy, and period.
and
pills,
pills.
birth control pills.
Mm.
Okay, you ask this, but in jargon way. In UK, I know they accept all these jargons. By the way, some doctors ask, is the vomiting is jargon? Yes, it is. But I guess in UK, they accept jargon, fever, and HIV, and all these things. But in overseas, better not to mention these words. So better to say any throwing up, any for the vomiting, any throwing up, for the fever, any high body temperature, for the what else, diarrhea, loose motion, and so on. Okay. The next system, yeah, the pills, yeah, oral contraceptive pills, you can ask any pills, birth control pills. Here you have to ask about miscarriage.
Mm.
Why? Antiphospholipids might be associated. So miscarriage, pregnancy, and period, and birth control pills. Okay. By the way, whenever you practice one case related to certain diagnosis, you will remember and you will do it perfect the next time. Clear?
Yeah.
Yeah. Any drug you want to ask about the recreational drugs, or any allergy, all this question makes sense. Any allergy because you might give this patient medication. Do you smoke? Do you drink alcohol? If there is affection to the eye, any vision problem, you can ask, do you drive? The job. You ask about the job, perfect, but you talked sometime. You didn't understand maybe. She was ice cream worker or just now she joined the work. But whenever you have ice cream, and it makes sense because these symptoms related to the ice cream and the cold exposure. Yeah, it's good to know the duration and the timing related to the symptoms, but be sure that you will give her advice instantly. Please try to change your job. If you couldn't, you can wear gloves while practicing your job, okay? Because it's most probably the trigger for your symptoms. But you have to know the duration as you ask. When exactly started? Is it related to the symptom? The symptom increase after? But why? Because you mentioned it to the examiner. It's mostly related to the job. Okay. And this is the history. If you repeat it again, please do it. Try to train how to do it again, and it would be more faster than this. The examination steps, Dr. Hanadi already mentioned, starting from the hand. While doing examination of the skin tightness, you have to know the level of the tightness. Is it above or below the elbow? Based on that, you can give the examiner the diagnosis. Is it diffuse or limited? Right? You have to know that. And ischemia or the ulcers related to Raynaud's, you have to check for the pulse. Don't forget. Dr. already Hanadi mentioned, but I'm trying to repeat quickly what's possible and important examination you have to do in this scenario. So rheumatoid arthritis, the joint deformity, here it would be corrected. Even if there is deformity, it would be corrected. What's called this, Dr. Dr. Ayula? If you have joint deformity with systemic lupus, what do you call it?
Joint deformity with systemic lupus.
Yeah. No, you didn't understand the question.
I know.
Okay, if you have joint pain with a systemic lupus, what do you call it? Joint pain, not deformity. Yes, Dr. Huda wrote it. Jacot arthropathy, right?
Okay.
Jacot arthropathy. But here the deformity will be, if there is deformity, will be corrected. But in rheumatoid arthritis, it wouldn't be corrected, right? Yeah, okay. This is regarding the joint and hand examination. That's sclerodactyly. You have to examine. Yes, you will feel the finger is tight. The ulcer itself, you have to examine the pain and the pulse. We already mentioned the skin tightness going up, the pulse. We finished the blood pressure vitals, and then the boxer myopathy. You can ask to do against resistance. This is for dermatomyositis in skin rash in the face. Sorry, above the eye. What we call it? Dr. Ayuna, rash above in the upper lid, eyelid, with dermatomyositis. Yeah, inhalator, perfect. Okay. The eye itself, is it dry? Is there any redness? Then the mouth opening, don't put your hand inside his mouth. Ask her to open her mouth and to just mention it is narrowing. Don't put any finger. Again, it's the welfare if you put the finger inside her mouth. Okay. Then the rash, systemic lupus rash. What do we call it?
What's rash?
No, systemic lupus rash.
Sorry, I didn't get what you said.
The rash for systemic lupus.
Okay, the name of the rash.
Yes, Miller rash, and the distribution will be in the nasolabial fold, right? Okay. Then the chest examination. Chest examination, or you can ask also for the back, for rash in the back. What we call it? Associated with dermatomyositis. Dr. Ayula.
Rash in the back associated with what?
With dermatomyositis.
I'm not quite sure.
Show sign.
Okay, sure sign. Okay, dermatomyositis, yeah, sure sign.
Yeah.
Yes.
Okay.
Sorry,
Any
I'm not
problem? No, it's okay. Any problem with the voice? You can hear well?
I think I can. I'm not quite sure what's going on, really.
Yeah, because I'm talking the earbuds. Anything? Is it clear for all?
Clear. Yes,
Yeah,
clear.
okay. Okay. Then the chest examination, as Dr. Hanadi said, you have to examine for pulmonary hypertension sign or crackles. Okay?
Okay.
when you will have the pulmonary hypertension, Dr. Ayula, and
Mm.
when you will have the crackles as interstitial lung disease,
Mm.
with which type? I'm giving you a question. What
Systemic.
type is associated with pulmonary hypertension of
This is
systemic sclerosis?
systemic. This is the diffuse type.
The diffuse will be associated with what?
The diffuse associated with the pulmonary hypertension.
No, the opposite. The
Mm.
limited with pulmonary hypertension, diffuse will be associated with interstitial lung disease. Remember, the diffuse will affect the internal organ, kidney
Mm.
and the lungs. So the lungs itself will be affected. I mean, interstitial lung disease.
Okay.
In the other arm, the limited type is affecting the skin mostly. So the vessels could be affected, and the vessels in the form of pulmonary hypertension, not the internal organ. Okay, just remember this while studying. If you have sclerodactyly and ulcers, Raynaud's phenomenon, and difficulty of swallowing, what we call this syndrome, and telangiectasia as well. What was the name of this syndrome, Dr. Ayula?
Did the crest syndrome?
Yeah, and I think Dr. Hani was about to mention it, or she wants you to mention it while discussing with the examiner. So
Okay.
this patient might have Crest syndrome because he has difficult swallowing. He has or she has sclerodactyly. She has also ulcers
Mm.
and renal as well. Okay, I think I'm done with the comment. You have any question, Dr. Ayula?
No.
Okay. Any question from Dr. Hanadi? You can write your scenario, Dr. Ayula, for Dr. Hanadi.
Okay.
We'll start in seconds. I will try to read the comments. But please, whenever Dr. Hanadi, you have something might harm the patient and related to the disease, occupational or social, address it immediately. Don't wait till the end. Okay. I mean, the smoking here is very important to address. She already stopped. She quit smoking, right? But after advice. So you can appreciate that. It's a good thing to do. And the second thing is the job. Please, either to change the job. No, doctor, I cannot. So you can wear gloves, and we will involve our occupational worker to help you regarding this. Okay, clear for all? Yes, okay. Your scenario, Dr. Ayula. Sorry, Dr. Hanadi. Mr. John Smith, 50 years old, complain of hand joint problem. Good. Same system. Take history and examine. Difference between Jacob and rheumatoid. Yeah, Jacob only pain. There is stiffness as well, but it's not more than 1 minute. Sorry, 1 hour or 30 minutes. The rheumatoid will be extended, but in Jacob it's not. There is stiffness, but it's not extended. And the deformity in the rheumatoid arthritis is corrected one, while the deformity in systemic sclerosis is corrected one. In rheumatoid, not corrected one. Sorry, I said corrected. In rheumatoid arthritis, it's not corrected. The Z shape, boutonniere, swan neck, the ulnar deviation, all this deformity, whenever you will see patient with rheumatoid arthritis, you will remember that. He cannot or she cannot move her finger well. She cannot do proper function. There is a lot of pictures in the Google. I can share it to see how is the fingers, and the deformity will not be corrected. It would be for a long time or lifelong. Is it clear, Dr. Ihda? Jacquard, Shawl, mixed connective tissue. Yes, mixed connective tissue, you can put it as differential. Miscarriage, joint deformity, yes. Peripheral vascular disease. I think we cover the whole comments in the chat box. Yeah, thank you, Dr. Ihda.
ممكن بس ضيف شغلة بسيطة؟
Yes, Dr. Hind. But please in English.
Yes, okay.
Okay, go ahead.
Functionality. You have when we examine the hand to think about the functionality, okay? So you should ask the patient to pick the coin. طبعا البيلو, Dr. Basim, he mentioned it. So you should examine on a pillow. Something important to add, scleroderma, scleroderma can lead to both correctable and non-correctable بتاعتها. correctable and non-correctable. الcorrectable صح مثل ما أنت قلت Jacob's arthropathy. لما بيكون في عندي deformity, when I have a deformity, I will ask the patient to make a fist, part of the functionality and part to confirm whether I have only Jacob's arthropathy or scleroderma on top of it, rheumatoid arthritis. Therefore, I will think of mixed connective tissue disease. So I have to, it's very important to ask the patient to make a fist. And then I will see if it is correctable or not. طيب still not, if he couldn't correct, it don't mean immediately that I should go for rheumatoid arthritis, because scleroderma can lead to another sort of joint deformity, which we call fixed flexion deformity. There is no deformity in the joints, but because of the skin tightness and because of the fibrosis of the tendons صار في شيء اسمه مثل قلصت الأصابع من كتر ما شد الجلد حواليها. So we call this fixed flexion deformity. This is not correctable. The patient will try to do the prayer and reverse prayer sign. He cannot. Fist, he cannot. But how you will differentiate from rheumatoid arthritis? There is no stiffness, there is no joint pain, there is no synovial thickening in examination. Tamam? It's more like a tight, very tight, shiny skin, and the patient cannot extend his fingers. Okay, and there is no joint pain mostly. Okay, so it will be the fixed flexion deformity of scleroderma, and usually it is not correctable. So all these things are important in the hand. Very nice point Dr. Basim mentioned about there is nice point he mentioned about tightness, skin tightness below and above the elbow. Sometimes it's more accurate to do it below the elbow and over the sternum to differentiate between limited and diffuse. And this is a very important step. And also pulmonary hypertension is more supportive of crest, while pulmonary fibrosis is more supportive of diffuse. And don't forget also that you mentioned something about steroid when she asked you about the treatment of scleroderma. What do you think about steroid in scleroderma?
Renal crisis.
Yes.
Yes, agree. So you have to be very careful. This patient is
Careful.
hypertensive and she's on ramipril and controlled on ramipril. This means there is an element of scleroderma renal crisis. So never ever mention steroid. And even if you are facing a flare and you think steroid might help, you should say I would recommend steroid, but with caution. In case the patient has scleroderma renal crisis, we might even avoid. Two diseases you have to think 100 times before you mention steroid: psoriasis and scleroderma. Never ever mention steroid without telling that it might exacerbate. We have to be cautious. And also in myasthenia gravis, usually they don't start myasthenia gravis patient on steroid except while being admitted in hospital, because there is what we call like a steroid dip in myasthenia gravis. In psoriasis, it can lead to exacerbation, and in scleroderma, it can exacerbate scleroderma renal crisis. So in these three diseases, think 100% before mentioning steroid. Yeah, mama. Yep, so this is regarding steroid. What else I want to tell you? Functionality we mentioned, limited versus diffuse. Always remember mixed connective tissue disease. You have really not to forget. I think they triggered this in your differential. Whenever you get any case of rheumatoid, the best differential is isolated scleroderma versus part of mixed connective tissue disease or overlap syndrome with something else. For example, if you get in this case proximal myopathy, or you get in this case Raynaud's phenomena, or you get in this case, for example, joint pain. So presence of proximal myopathy or joint pain or Raynaud's can be part of scleroderma, can be part of overlap, can be mixed connective tissue disease. So as soon as you get one rheumatological disease, you should be very happy because the three differential are ready. The top differential is the disease which you could collect most of its clinical features during your history and examination. Second is overlap. Third is mixed connective tissue disease. As simple as that. And whenever we discuss overlap and mixed connective tissue disease, the most important question raised usually is what is the difference between overlap and mixed connective tissue disease? Without going into too much detail, overlap, you will find the serological features of every disease. If you have a scleroderma, you will have a SCL70 or anticentromere. Overlapped with dermatomyositis, you will find MI2 and JO, anti-JO. So since the serology, both serology characteristic for every disease are present, this means there is an overlap. I have the serology of scleroderma plus the serology of dermatomyositis. So simply I have an overlap between dermatomyositis and scleroderma. If I don't find the serology characteristic of a single rheumatological disease, I find, for example, a titer of SCL70, which is not fulfilling the criteria, or I didn't find the autoantibody at all, but I found the U1 RMP positive, and the whole serological panel is not characteristic of single disease. At that time, I will say it's mixed connective tissue disease because I couldn't prove a serological marker for a single diagnosis. There was either either it is positive but not fulfilling the characteristic titer, or it was not there at all. So I found you one RMP positive. So as simple as it will be a mixed connective tissue disease. So the difference is mainly a serological difference. Okay. On top of it, the features. So the features can give you a clue, but the main clue you got it from the serology. So those three differential are ready for you at any time you have a rheumatological condition. But the trick before you use that list of differential, you have to do the rheumatological panel. You have to ask about the dryness, rhinos, soreness of the mouth. SLE is very important association with scleroderma. So I was expecting soreness, hair loss, miscarriage, clot. You didn't ask about clot history. Any rheumatological disease, clot history is very important. Okay, so keep it as a part of your rheumatological panel questions. So SLE is very important. Sjogren is very important. Rheumatoid and Raynaud's are very important. Polymyositis, dermatomyositis are also important. You have to screen all of these things. As soon as you do this screening, then you will be relieved and you will be allowed to use that list of differential diagnosis. Okay, and that's it. I don't remember any more comments. MashaAllah, yani everything was mentioned by Dr. Basim and by the doctor who gave you the case. Okay,
Okay.
so
Yeah. Thank you, Dr. Hind. Thanks so
yes.
much. Yes. Any question before moving to the second scenario?
Dr.
So
Basim,
this,
please.
yeah, sure.
Here in Reno phenomena, do you need to do any investigation, special investigation for Reno? Like
Renal
capillary
phenomena.
something?
Yeah,
Yes,
yeah, yeah, yeah. She
capillaroscopy.
mentioned capillaroscopy. Yes.
We need to do, right?
Yeah.
Exactly. Yes, you have to. So this is
And
specific
also
test
maybe we
for
need
that.
to check also the feet
Also
for
exhibit.
any amputation and toe
Yes, you're right.
abnormality. Yeah.
Yes, you're right. So you'll
Thank
examine the toes and fingers as well. Plus the
صح.
capillary. Yeah, continue,
يلا.
Dr. Hind.
لا كمل دكتور بس تذكرت شغله
No,
خلص
no, I want to
اسالكم
add,
اياها
yeah,
بسرعه كوني
I want to add
قاطعتك.
only capillaroscopy, but that's it, because it was asked by the examiner, but Dr. Ayula forget, and I forget also to comment.
Usually we offer it as a bedside بالexamination at the end
Yes.
whenever لأنه Raynaud's phenomena is a history wise. Nothing can prove it لأنه patient in the clinic he don't have any trigger. So the only examination you can do bedside is capillaroscopy. And usually it is better to mention it as a bedside examination along with the urine analysis and renal pruit if you
Yes.
didn't do the abdomen as a part of scleroderma renal crisis investigation يعني especially if you have a high blood pressure from outside. طبعا نحن عم نعمل الرينال بروي it's not because it's part of the renal scleroderma renal crisis. The mechanism of hypertension scleroderma renal is different, but as a part of screening for secondary causes of hypertension in young patient. تمام? So don't mix it up. Okay? But it is
Yeah.
still an important thing to be done in young patient who have a hypertension from outside. and we said
Yes.
capillaroscopy and urine dipstick. فهدول يعني things are important to be offered. الشغلة الثانية اللي تذكرتها إنه في عنا very characteristic skin rash which is characteristic of scleroderma other than telangiectasia or other than the skin manifestation of dermato and SLE, which is what? And usually when we see this rash, we mix up everything because we don't know it's a characteristic rash in scleroderma.
Vasculitic rash,
Salt and pepper.
reticularis,
Salt and pepper.
عليك نقول
livido
إنها
reticularis.
salt and pepper. Livido
Yes,
reticularis.
salt and pepper.
الفاسكوليتيك راش could be بس you will you يعني it's not characteristic for scleroderma. معناتها انت لو شفت البربريك راش you have an overlap او نفس السكليروديرما عملت لك vasculitis. لكن
Yes.
salt and pepper is characteristic for scleroderma and unfortunately we always miss it.
Yes,
Whenever
you're
it
right.
appear we mixed up everything. تمام. and we think of psoriasis vitiligo يعني بتخرب علينا الكيس كتير and it is simply associated common association with scleroderma. Salt and pepper rash in the face and in the hands, in the chest, in the back. تمام. and usually it is not photosensitive. and يعني when you examine it you will find the skin tight over it. You will know that it is related to scleroderma. And something else, whenever you are talking to the examiner, don't say a small mouth opening or limited mouth opening. You should give the signs its medical term. Microstomia, peaked nose, buckled mouth, okay? Tight, shiny skin. So, يعني try to use the medical terms whenever you are talking to the examiner. First thing, in order to enumerate the signs quickly and save your time. Second thing, it is not professional when you define the signs in a non-medical terms يعني. تمام. This is the two things I remember. Okay.
Okay.
Thank you
Yes,
so much, Dr.
great.
Bassem.
Thank you, Dr. Ann. Thank you. Any question else before starting the second scenario? So the second scenario, Mr. John Smith, 50 years old, have complaint of hand joint problem. Big history and examine him. Ready, Dr. Ayula and Dr. Hanadi?
Yes.
Yes, here you go.
Hello,
Hello.
I'm Dr. Ahmed, one of the doctors in clinic today. Are you Mr. John, 55
Yes,
years old?
Yes, I am.
Mr. John, I want to take history from you, examine you, and will answer all your concerns. Is that okay with you?
Yes, it is, doctor.
Okay, Mr. John, it came to my knowledge that you have been complaining of joint pain
Yes.
in the hand. Can you tell me more about that?
I've been having joint pain in my hand, and I've had it for about 1 week now, doctor.
1 week. Okay. Is it the first time to have this pain?
No, I've had it before.
When you have had it before?
I have it a couple of times. It's been a while, but I've had it like about 3 times in the past. But this recent one started just about a week ago.
Okay. Did you seek medical advice for the previous ones?
No, doctor.
Okay. And how it resolved? Is it
I used some painkillers and it went on its own.
Okay. And is this pain similar to the previous one?
Yes, similar exactly. So I thought to get it checked now.
Okay. May I know where exactly? Can you show me?
Yeah, it's just in this middle finger on my right.
Yes. Only the middle finger?
Yes, doctor.
In your right hand? Okay. No other side of the pain?
No.
Okay. And since it is started, is it increasing, decreasing, or the same?
It increases. Since started, it's just there. Well, it's just this. It increases.
Okay.
I'm using painkillers and it's helping.
Is it started suddenly?
Yes, suddenly.
Okay. And Mrs. John, if I give you, Mr. John, if I give you from 0 to 10, 0 is the minimum and 10 is maximum, how you will scale your pain?
I'll give it an 8, but it's getting better now with the painkiller.
Sorry for that. If you wish to have again painkiller, let me know.
Okay, doctor, thank you.
Okay. Okay, Mr. John, anything relieves this pain apart from
Painkiller,
painkiller?
doc. Nothing else.
Did you notice anything increase this pain, like movement?
Movement sometimes.
Movement increase the pain. Okay, sorry for that.
Thank you.
And any associated swelling?
Yes, doctor. It's swollen.
Okay. Any stiffness?
I've not noticed that.
No stiffness. Okay. And apart from this pain, any skin rash?
No.
Okay. Any muscle pain?
No.
Any muscle weakness?
No.
Okay. Any mouth soreness?
No.
Any skin rash?
No.
Or rash when exposed to sun?
No.
Okay. And Mr. John, do you have any medical condition I should be aware of apart from this recurrent joint pain?
Yes. I have a blood pressure issue.
Okay.
And it was just about, it was needed about a month ago.
1 month ago? Okay. Are you on any medication for that?
Yes, doctor.
May I know the name?
I can't remember exactly, but I think it's something Tazide or something. Yeah, Tazide, yeah.
Thiazide? Okay. This is for 1 month. Any recent increase in dose?
No.
Any other medication with this?
No.
Okay. Any allergies to any medication?
No allergy, doctor.
Okay. Mr. John, do you have any temperature?
No.
Any lumps or bumps?
Well, I've noticed some lumps in my legs and also in some of my fingers as well.
Legs and fingers. How it looks? Is it hard or?
You said what?
Is it hard?
Yeah, it is. Yes, it is hard.
Okay. Is it one lump or more than one?
It's more than one lump.
Okay. Any pain when you touch it?
No, they're not painful.
Okay. Okay, Mr. John. Any tiredness?
No.
Any change in weight?
No.
Any change in appetite?
No.
Okay. Okay, Mr. John. Do you have any change in your water wall system?
No.
Color, amount, or frequency?
No.
Any frothiness?
No.
Okay. Any cough?
No.
Coughing up blood?
No.
Okay. And what about your bowel habits? Any loose motion?
No.
Any tummy pain?
No.
Any tummy swelling?
No.
Any throwing up?
No.
Any headache?
No.
Any loss of consciousness?
No.
Okay. Any change, any weakness, limb weakness,
No.
or change in sensation?
No.
Okay. Any family history of similar condition?
No.
Any family history of joint disease?
No.
Okay. Any history of hospitalization before?
Yes, doctor.
May I know for what?
I've had a stone in my kidney, and that was removed
When was that?
about 2 years ago.
2 years ago. Okay. Okay. Mr. John, what is your job?
I'm a teacher.
How this symptom impact on your job and daily activity?
Well, I'm able to carry on with my job really.
Okay, I'm sorry for that. I will try my best to help you, and I can involve social worker and occupational workers to help you also.
Okay, doctor.
Okay. Do you smoke?
No, I don't.
Okay. Do you drink alcohol?
Yes, doctor, I do.
May I know how much and over how long?
Well, I take quite a lot of alcohol really, and I've been drinking it for a while now. I've been drinking it for over 10 years.
Okay. And the amount?
I take quite a lot, and I take all sorts. I take spirit, I take gin, a lot of alcohol.
Okay, Mr. John, I highly advise you to moderate your alcohol intake as this may aggravate your condition. Is that okay with you?
I'll try.
If you wish, I can refer you to alcohol cessation clinic. They will help you.
Okay, doctor.
Okay. Can I examine you?
Yes, sure, doctor.
Okay, before I examine you, any history of trauma?
No,
Okay. So, is there any pain right now?
no, I don't have any pain. I can manage with it.
Okay, I will put a pillow. Then I want to inspect the site of the pain.
Okay,
Any deformities?
There's swelling around the middle finger on the right. So I'm sending you the image of the rash
Okay.
now.
Any redness?
No redness.
Okay, I will touch gently. Any effusion?
No effusion.
Okay. And temperature over the site?
Tender.
Comparing to the
Warm differential warmth.
warm. Okay. Okay. Can you take this coin for me?
Okay.
Is it possible?
Yes, I can.
Okay. Okay, Mr. John, if I tap here, any pain?
It's a bit. It's painful.
Okay, sorry for that.
I shared the photo in the chat box. You can see the finger and the hand.
Okay. I will check also for the nodules.
The what?
Nodules.
Nodules. Okay, the one.
Tophi, I mean tophi, sorry.
Okay, the one I said I have, but I'm swelling in my body, so I'm gonna send you some image as well.
Okay. Okay, what about the vital signs?
Vital signs are good.
Okay. Any then I will move to the proximal myopathy.
No proximal myopathy.
Okay, Bella and jaundice.
No.
Okay. And mouse, any mouse soreness.
No soreness.
Okay. Then I will just sculptate the heart.
Okay. No mouth sound.
The chest. Any crackles or
no clear.
superficial palpation for the abdomen.
Okay.
Any tenderness?
No tenderness.
Okay, then I will examine for the rash for behind the ear and the scalp, and if there any visible rash or in the tummy or the back. No.
Some swelling on the hair, which I've sent the image in.
Swelling?
Yes, on the ears and then.
Yeah, there
okay.
is another photo shared in the chat box. You can see his ear.
Okay. Then for the joint, if any joint pain? I mean, or examine for the joint, for the knee joint.
No pain.
Any lower limb edema? I would press.
No.
Okay. May I know what is your concern?
I'm just concerned about what might be going on, doctor.
Okay, Mr. John, from what you told me, and after examining you, most likely you have a condition called gouty arthritis. This is most likely increased by the medications that you are using to control of your blood pressure, and it is due to increase to certain protein in the body or mineral. We called it uric acid.
Okay.
Explaining all these symptoms that you have, and we need to run some blood tests and some imaging to rule out other causes.
2 minutes left.
And I will refer you to join doctor and the group of specialists, including social workers and occupational workers, to help you also. And also, I advise you just to control your protein in your diet, as this can also aggravate the condition. And as I told you, to moderate your alcohol. Okay.
Okay, doctor. Thank you. But you mentioned that you want me to stop this. This is due to the medication I'm taking. So how will I control my blood pressure?
Okay. Sorry, will involve also heart doctor to will stop this medication and involve him to change to another type of medicine.
Okay, doctor. What
Is
type of
that okay with
medicine?
you?
Yeah, it's okay. It's okay. Thank you, doctor.
Welcome, Mr. John. Do you have any other concern?
No, doctor. But this pain, how are you going to give? What are you going to do to my pain, doctor?
This pain, sorry?
Yes, the pain. Can I just carry on with the painkillers?
Yes, but this should be, we will give painkiller, but we will avoid certain type of painkiller. So also advise you not to take over-counter medication, only the prescribed one. Okay?
All right, doctor. Thank you.
Thank you, Mr. John.
You're welcome, doctor.
Yeah, perfect, Dr. Hannah. Great, amazing. Time is up. Now we can start the question from examiner, Dr. Nadim. Dr. Ayula, please.
Well done. Can you summarize your findings?
Yes, Mr. John, 55 years old, male, came with middle finger pain for the last 1 week. He has previous history of recurrent condition before, and he has high blood pressure, given thiazide for control, and other symptoms I could not appreciate. On examination, he has inflamed middle finger, red and swollen, and function is intact. Apart from that, there is tophi spread over the hand and in the ear, and vitally stable. There is temperature 37.5. No other finding.
Okay, so what are your possible differentials?
Okay, my first differential is gouty arthropathy. It could be also psoriasis. We need to rule out, and it could be ankylosing spondylitis. Again, is that no other features? It could be enteropathic arthropathy.
Okay. So this man is on you think the causes might be due to thiazide? So how would you what other antihypertensive will you prescribe for this man if you want to?
What? Sorry, did not get.
Blood pressure medication, antihypertensive, that you would want to prescribe for him.
For him, we can give all other calcium channel or beta blocker.
Okay.
Or ACE inhibitor.
All right. So how will you manage? How will you investigate?
Okay. I will do complete blood count, ESRC reactive protein, kidney function, urine analysis, and liver function. Then I will do serum uric acid and X-ray of the hands. And we can do aspiration to rule out septic arthritis, joint aspiration.
Okay. Any other investigation you want to do?
Investigation?
Yes.
Imaging? Chest X-ray of the joint.
Okay. All right. So how will you manage in terms of medication, the treatment?
Okay. In the acute attack, we'll give painkiller. Then for prevention, we'll give allopurinol or colchicine.
Okay. So if this patient have you'd have the renal function test and it's deranged, the creatinine is deranged. So how will you manage the pain?
We'll give paracetamol. We'll not give non-steroidal anti-inflammatory. And we can give colchicine.
Okay. All right. Yeah, that's well done. Thank you.
Thank you, doctor.
Still 1 minute left. Let me ask you a question, Dr. Hanadi. So if contraindication in case of renal problem, what you can give?
For the painkiller?
Yeah, and for the inflammation.
We can give intra-articular steroid.
Yeah, perfect. I hope you didn't read it. Anyway.
I read it.
Okay, so this is the option, the last option. If you have contraindication to non-steroid, you can inject intra-articular steroid, particularly if you have monoarthritis. And other questions, I think time is up. Okay. Now we can start the comment, Dr. Ayula. Well done, Dr. Hanadi again. Let's start the comment. I will comment.
Thank you.
Well done, Hanadi. It was a good presentation. Good history taking and good examination. Well done. The diagnosis was right. And just some few things about the history that I think might help. Okay. The way you started with the history, you analyze the symptoms so well, and you ask relevant question in analyzing the symptoms. But the identifying risk factors for this trigger, this acute flare of his gouty arthritis, you're able to identify thiazide, okay? But there are other things that would have been beneficial in asking in the history. Do you ask for alcohol? But you neglected diet altogether in the history. Do eventually in the history, in the manage, you eventually told me about protein food. If you have had me for diet, I will have told you that I eat more of seafood, and that will point you, because we are familiar with red meat to be high in purines, but seafood as well is high in purines. I will have told you I like seafood. I don't eat red meat at all, but I like seafood. That will have been one thing I will tell you. And then I guess the renal stone also point you to the direction that is likely to be gouty arthritis, right?
Sorry?
I said the renal stone also pointed you to the point that it might be an gouty arthritis. Okay,
Yes.
well, yeah, well done. In the examination, always remember to offer bedside urine analysis in such case like this. You never can say, am I picking any renal renal impairment at that time? Like, as we know that gouty arthritis, one of the complications is renal failure. So at that point, you might be picking one sort of proteinuria, hematuria in urine. So it's always good to offer bedside urine analysis. And also in the investigation, you did every of the investigation, but you left out one important thing, which is joint aspiration to check for negative bifurcated crystals. To get to check for the crystals. Okay. And
Yes.
yeah, so how will you differentiate it from pseudo gout?
Gout.
With this with the bifringens, how will you differentiate gout and pseudo gout?
Yes, negative and gout and positive in pseudo gout.
What's the shape?
Not sure.
What's the shape of the crystal? In gout is needle shape, and in pseudo gout is rhomboid shape. Positive rhomboid shape bifringent crystal, and in gout is needle shape negative bifringent crystals. And what's the name of okay? So you talk about the septic arthritis thing, which is good. So the treatment, okay, and then the antihypertensive, the one you will have prescribed will have been ARB, losartan especially, because it's been found that losartan also lower uric acid. So apart from working as an antihypertensive, it will also lower the uric acid in this patients. So I wanted to ask you about allopurinol again. What is the the side effect of allopurinol? We all know that it can cause Stevens-Johnson syndrome and epidermal necrolysis, and it's always good to check for the HLA-B 5801 before starting it, especially in some particular set of people. I think in Thai people and Korean, I'm not quite sure. But it's always good to check, to screen for that because of the risk of allopurinol, should in case that is hacks in.
Check for what?
HLA-B 58 if you want to comment on allopurinol because of the risk of Stevens-Johnson syndrome. Okay. I think Dr. Basim have asked about the steroid as well. So yes. Okay. So I think that's all. Thank you. Well done.
Thank you.
You're welcome. Hello, I'm done. Thank you.
Yeah. Okay. Thank you, Dr. Ayura. Good comment and good case, good preparation, and common scenario in basic, by the way. Hypercalcemia either related to the drug induced, or gouty arthritis because of thiazide, increased thiazide after thiazide, increased uric acid after thiazide, or diet habits, increase the purine containing food, or high protein food, or alcohol, or as Dr. Hind mentioned, the lymphoma as a trigger for the breakdown of the cells. These are the possible common causes in cases. Can the patient present with gout? And exaggerated by some factors, the patient will present with gouty arthritis even with 2-5. So the case was straightforward. Dr. Hanadi, mashallah, tried to pick up the possible cause, and the case and the conclusion for the case was from the thiazide and the alcohol intake, the joint pain, which is mechanical, seronegative arthritis. She tried to rule out other possible trigger, but she missed the diet habits. I think she learned from this, Next time, the question for the right should be from the start, or since you suspect there is gouty arthritis and it could be related to the food or whatever the trigger factor. Okay. From the history, I guess also, Dr. Hanadi, I tried always to make the systemic review systematic because they don't like to ask question from GI, then CNS. What I believe they like to ask as a systemic from up downward, the head or the CNS, then the pituitary or sorry, the endocrine, then the cardiovascular, respiratory, abdomen or GI, and the renal at the end. Here in this scenario, the relevant system is musculoskeletal. You analyze it perfect. You ask about everything, swelling, but you miss the trauma. However, you remember at the end because trauma also could be the reason. Patient might be hurt by any trauma, and this is hemothorax, or sorry, hemoarthrosis or some hematoma. Okay, this is another issue. The examination perfect. Also, you covered all examination steps. The hand, putting the hand on the pillow. Whenever you have hand complaint, ask for pillow. Ask the patient to sit. Please put your hands here and start to examine the hand. Okay, don't examine the hand in the without the pillow. I mean, clear. The other thing in the examination, as Dr. Ayula showed us, the ears and the toes to find commonly in the big metatarsal, right? In the big toe, in the base of the big, at the base of the big toe. Here in this scenario, you have to expose it, even if it doesn't show any symptoms, or if you ask and he denied that, you can expose it. He might have it there. Okay. Hypertension and vital you have to offer. Renal as examination, I don't think there is a need to examine for kidney or to ask. If he has tummy pain or flank pain, this time you can examine it. Otherwise, no need. But the analysis for the past medical history was good. That's why she discovered that the patient is having renal stool after renal colic at admission, and he discovered or they found that this patient is having renal stool, which mostly it's uric acid stool. Could be calcium, by the way. Thiazide increase uric acid and calcium. Okay. Dr. Ayula already covered the topic well as investigation. She added very important investigation, the gout or the joint aspiration. Septic arthritis, you should put it in your differential. Whenever you have patient admitted with severe pain, joint pain with redness or hotness, put the most serious differential in your list. Why? Because this patient, if you misdiagnose him or you underestimate the pain and the joint problem, giving him non-steroidal without suspecting septic arthritis, it might lead to septicemia and the spread of the infection, dissemination, and the patient might be in shock. It might be a irreversible shock because of septic arthritis as misdiagnosed earlier. So always give the most important or the most relevant condition, which is gouty arthritis. However, the second differential, you should put the most serious condition, septic arthritis. The same as for confusion last session, we mentioned confusion as acute confusion state. However, I should rule out meningitis or encephalitis because it's most serious. Okay. So always think about the most serious differential to your case and give it as a second. And you can say against that. However, I should roll it out by blood test or by other workup. Clear? Anyone has question? Dr. Ayula first and Dr. Hanadi. Dr. Hanadi, I think this first time for her with us in the session, and she
Yes,
did great.
that's fine.
Yeah, really, you did great. The most important and impressive thing here, you were calm even while asking the question. Sometimes I feel like you are not yet collected the diagnosis, but you are calm asking the question with calm way. That's why you can get your diagnosis easily. Okay?
Yeah, but not in the exam, unfortunately.
No, it's okay. At least train to do. Of course,
Yes.
the exam has another stress. But with the time, with the practice, frequent practice, you will be very fast taking history and fluent, and again still calm because you practiced this case before. Imagine if you go to the exam tomorrow. I'm talking about anyone, any candidate. He's going tomorrow to the exam and he found patient with ulcers. Oh, he's lucky, and of course he can do it easily way because he just remember the approach or the scheme he did or we did yesterday. So it's a matter of practice. Practice with whosoever, either in a meeting or with partner. Why? Because whenever you are practicing frequently, you might do a case and you will have this case in the exam. And the case, as we know, is repeated from diet to diet, from center to center. That's why I encourage everyone to practice anywhere. Well done, Dr. Hanali. Thank you. Any question?
Dr. Bassem,
Yes, Dr.
I
Hanali.
want to
Thank you.
ask about the monoarthritis with the fever. It's indicated
Yes,
for admission as a septic arthritis for aspiration or
yes.
not indicated?
No, it's indicated. Septic arthritis, monoarthritis mostly, or the septic arthritis mostly present with monoarthritis. It will not be mini joint as septic. But if you have polyarthritis, you can have another condition. So either rheumatoid or seronegative or seropositive. But to have one joint, monoarthritis, single joint, you have to have the signs of infection: hotness, redness, tenderness, limitation of movement. If you have such manifestation in any patient with fever or constipation symptoms, definitely you have to admit this patient to take blood culture, to start antibiotics as soon as possible, to try to aspirate this joint after confirming coagulation profile. Okay?
Okay, Dr. Bassem, there is another question but not related for this case. Can I ask?
No worry. Yes, sure.
If there is a history of patient with back pain and the history go with the ankylosing spondylitis,
Yes.
but the site of the pain not in the lower
Back.
of the back,
Yeah.
in the thoracic area. When
Okay.
I want to examine the patient, I do Schober test and another test like
Yes.
what I will do.
Yes, you have to do all the tests and examination steps for ankylosing. It's not a matter of is it related to the pain or no. You have suggestion of ankylosing. I have to do the test for ankylosing. I want to show the examiner that I want you to know that I am doing the steps for ankylosing, even it's negative. You get it. You suspect ankylosing in high possibility. So I have to do the steps, the tests for ankylosing or clinical tests.
Okay, and when I want to examine the thoracic area, what I will do? Only
You
inspection and palpation, anything, another
Yes,
movement for the
limitation,
thoracic?
movement. Yes, the movement, right, lateral movement and forward movement, and the neck movement, occiput wall test, as well as the modified Schober test. It's not a matter of
Okay, thank you, doctor.
one area affection. Ankylosing might affect any areas, start from sacroiliac joint, extend to the whole back joints, right? All vertebral joints. This is what's called bamboo sign, syndesmoid. All these things might be presented soon or later. Okay, so it's not only as a segment or part of the vertebral column would be affection. So I will examine this part only. No, I have to examine the whole back. Clear, Dr. Huda? Any other question?
Okay, doctor.
Yes,
Yeah,
Doctor.
don't.
Can you?
Yeah. Yes, sure. Go ahead.
Yes. Can you repeat the differential diagnosis for the last case, please?
The first diagnosis and differential would be gouty arthritis, complicated by tophi. You have to mention tophi, Dr. Hanadi. You said gout arthritis only, but there is tophi, which is painful. And maybe
Yes.
this is the cause of presentation. He has pain, not only on only the joint, it might be the tophi itself. Okay, this is the first differential. The second, as joint pain, septic arthritis, and I should rule out septic arthritis. Third, you can say any seronegative arthritis, pseudogout, or you can say seronegative arthritis, reactive arthritis. Okay, so the most important to say the case or the diagnosis in this scenario, the septic arthritis as second possible, and seronegative arthritis you can mention. You can say also the psoriatic arthritis. Against that, no rash or no nail change. Or reactive arthritis. Against that, no urine change or no change in the water work or discharge coming. Enteropathic arthritis, against that, no change of the bowel health or no signs suggestive of inflammatory bowel disease. You got it?
Thank you. Yes.
Yeah, most well. Any other question or comment? Any doubts?
دكتور باسم بالنسبة للمانجمنت أو التريتمنت يعني بعد أقول pharmacological treatment non
Yes,
pharmacological
I prefer
treatment
to
وأقول
start in this one.
أيوة
Multidisciplinary team approach.
أيوة بالنسبة للميديكيشن الألوبيورانول better to mention it or better to say I will refer the patient to rheumatology clinic.
I prefer to start with multidisciplinary team approach until reaching to the point of pharmacological. If the examiner asks you what options you know as the pharmacological option in this scenario, now you can start to mention them. But the best way is to refer the patient to the rheumatologist, and he will start him on either painkiller according to the renal profile, or maybe he needs to give steroid or intra-articular steroid. And for the gout itself, either chronic or acute, you can answer in this way. So he will understand that you know how to answer. In the acute form, if the patient wasn't on allopurinol, so it's better to wait until the flare-up will improve or settle. If the patient on allopurinol, he can continue. This is what you know, and this is the
But
way
if
how to answer.
not on allopurinol, I will not say I will start allopurinol and I will refer the patient.
Exactly.
I will tell I will refer the patient to
Not refer,
rheumatologist.
multidisciplinary team approach. This
Uh-huh.
patient need to be followed by a kidney, renal, as renal profile. You don't know his renal profile, and cardiology as well to change his antihypertensive, right? Always start your management plan for multi-system disease. Start with multidisciplinary team approach. What team doctor you will involve here? You can say cardiologist for the medication to be changed. The second thing, nephrologist. He might have kidney infection and renal stone. Already he had history of renal stone. And on the top of this team, the rheumatologist, the doctor who will follow his gout, and he will mention the medication he might be in need for it.
Thank you.
Okay. Thank you, Roxana. Any point to be raised?
Can I
I'll
add?
try. Yes, I was about to read your comment, but you can already read it, or you can mention what you want, Dr. Hind. Go ahead.
اوكي خلينا نخليها للاخير بما انه مكتوبه على الاغلب الكل قراها، بس كان بدي اضيف
Okay.
شغله انه
Sure,
الجاوت
yes.
انجلش حاضر. The gout
Yeah.
usually is managed in the primary care. Okay, usually gout is a very common, something like you can say يعني common cold, so you don't need always to mention I want to refer. One thing that I should remind you انه once Dr. Poo, she did a gout case and she asked when we should refer gout to a specialist. This was an examiner question. And we can deduce from this examiner question that we don't refer all the time the gout patient to a rheumatologist. Because usually management is simple. Colchicine or non-steroidal. If we have a kidney issue, it will be colchicine. If we don't have a kidney issue, we can start with non-steroidal. So that day she asked us, like the examiner question was, as soon as the candidate mentioned MDT, involve the rheumatologist, immediately the examiner told him what are the indication to refer gout to a specialist, يعني rheumatologist specialist. So I look it up. I don't remember wallah if she answered it or not, because sometimes they ask the candidate and then they forget. But from clinical knowledge summary تبع UK, I found that they said refer to a specialist or seek a specialist advice when there is a suspicion of an underlying systemic illness. For example, اللي هي high turnover disease, like connective tissue disorder, rheumatoid arthritis, or gout occurring during pregnancy or in a young person under 30. لأنه people under 30 inherited causes are more common or serious causes. So whenever there is positive systemic symptoms and you are suspecting either rheumatoid or other connective tissue or any high turnover condition like psoriasis, lymphoma, whatsoever, pregnancy, and young people less than 30. An intra-articular steroid injection is indicated because this modality of treatment is usually only done by a specialist. But the facilities or expert خلاص ما لنا داعي بالباقي. Complications are present. The most important complication, which is also remind us with what question and examination we should include in our scheme. First, chronic arthritis. That's why Dr. Bassem, when he said, you should say this is not a case of a gout and you stop. It's a chronic tophaceous gout because you have chronicity in the form of previous attack. You have tophi and you have an acute attack now. So either acute on top of chronic tophaceous gout, or you can say immediately it seems that you have a flare and he have already chronic tophaceous gout. So your diagnosis matter. Sometimes it's not enough to say neurofibromatosis. You have to say one or two. It's not enough to say systemic sclerosis. You have to say limited or diffuse. It's not enough to say gout. You have to say acute or chronic. So sometimes really even in infective endocarditis, it's right side if there is IV drug abuse, or infective endocarditis, which is usually left side. So sometimes really it matter, and you'll find the examiner ask you, do you want to specify? Do you want to make any addition to your differential or your top diagnosis? So at that time, think, is there a type? Is there something I missed? Localization, something trick in the top differential you have mentioned. So chronic arthritis is the first. So this case should be referred to rheumatology because there is a sign and symptoms of chronicity. Second, gouty tophi. If there is a previous attack, this is indicate chronicity. If there is tophi, you should refer, and it's one of the complication. Renal stone, that's why I like this case too much. It's contain most of the complication. Third complication, whether it's affecting the kidney profile or not affecting the kidney profile, any kidney stone should be referred. And you should include in your urine analysis for renal stone, because this kind of urine analysis for crystals is usually a specific kind of urine analysis. Okay, it's not the usual urine analysis. Affecting quality of life. As soon as there is impaction or it is impacting the daily life activity or job by itself, an indication to refer to a specialist. The person is at risk of adverse effect of drug treatment. If he gave you here history of allergy, is very important, because if the patient have any kind of allergy, this patient need to be screened for HLA, need to have a detailed history, what kind of allergy he had, and at that time you can decide whether you can start allopurinol or not. So if the patient has any adverse effect of drug treatment before, whether renal affection, hypersensitivity, whatsoever. Okay. This is refer to a specialist or seek a specialist advice. They separate in it. It was like mentioned in detail. They once mentioned when to refer to a specialist, and once they mentioned when or consider referring a person with gout to rheumatology services. They said if the diagnosis of gout is uncertain, the response to treatment has not been adequate, or the treatment is not tolerated, treatment is contraindicated, the patient have CKD stage 3B or below, they have had an organ transplant. At that time, you should also involve the rheumatologist. Okay, so they said specialist advice most probably it could be related to rheumatology or something else. I tried to find out what is the difference between Rheumatology services and specialists, I couldn't. So keep it all together. If it is a complicated case with complication, special age group, pregnancy, systemic illness, if the patient is not tolerating the treatment or have adverse effect of treatment, or the patient has any kind of allergy, refer. Okay, so those are the big headings. When it is a complicated case of gout, you have to refer, and at that time, you have to mention MDT. But if it is the first attack, simple, no renal involvement, no complication, just alcohol, just dietary habits, you have just to modify those issues or review some medication, then no need to refer. You will review the drug with the concerned team. You will involve the dietitian and give dietary advices. And in this case, I think alcohol, she was pushing you toward telling you, doctor, I'm consuming too much. So you should ask her, when did you start consuming too much? You have to specify the temporal correlation, because at that time her symptoms worse, and at that time she started to have recurrent attack, or he, I think he was a male. So you should ask, when did your consumption started? And if you find that it is usually they start asking KJ questionnaire whenever it's above 20, because usually dependency is at this level or above is common. And if you don't have time, it's very simple. If you don't have time, at the end of your examination, you will say, I would like to offer KJ questionnaire, because it's part of examination or it's part of history. You can integrate it with any part. So don't panic. You don't have time, but your patient here, it's very important to mention KJ questionnaire, because alcohol is a top. And I didn't hear you telling her that I would like to refer you to the anonymous clinic or alcohol liaison services. I didn't
No,
hear you
she
mention
referred. She referred. Yeah,
خلاص.
but she said alcohol cessation clinic, which is, as you mentioned,
There is
anonymous.
nothing
Yeah,
called alcohol cessation, because we never
yeah,
cessate alcohol. It's like a
exactly.
smoking. So always mention alcohol liaison services or anonymous clinic. Okay.
Okay.
Or if you are in stress, to specific clinic,
Especially, yeah.
yes, helping you to stop, helping you to manage your alcohol
Yes.
issue. تمام؟
Specialized team.
يا ماما صوتي عالي، آسف.
Sorry. Any team you don't know the main name, you can say specialized team.
Yes.
Exactly.
And then
Okay.
you make any specialized clinic. تمام؟
Okay.
I think, and also you should mention in the concern what are the triggers. So if you would pick up the diet, you would mention the diet
Yes.
is a problem, alcohol is a problem, thiazide is a problem. I don't know if you examine for dehydration. Dehydration is
Yes.
very
Perfect.
important in any gout
Yes.
case. You should ask about vomiting, nausea, diarrhea, and you should look for the postural hypotension, and you should examine the mucosal membrane and skin turgor. Okay? So
Yes.
dehydration
Yes.
is very important in gout
Yeah.
case. So losartan was a very nice addition. ماما والله خلاص اعتذرت منك أنا آسفة. And cardiovascular risk factor in the investigation. You should do lipid profile, DM profile, because usually gout is part of the metabolic syndrome.
Metabolic
So
syndrome.
probably yes, you have to screen for the other metabolic syndrome points. And ultrasound, please. Now
Kidney.
ultrasound has an important role in vasculitis. Ultrasound has an important role in any joint problem. Okay, so vasculitis, joints are now ultrasound is very important. Okay, so include ultrasound, not only
Yeah.
X-ray.
Yes.
Okay, and I don't
Yeah.
know if I mentioned anything in the points, which I forget to say while I was mentioning. Yes, whenever you
Yeah.
mention aspiration, never ever do aspiration without coagulation profile. Either you can mention it in the investigation or in the management. يعني later on that I might do coagulation before I start. I might يعني make sure even if you forget the kidney, whatsoever
Yeah.
happened with you, always pick it up. Pick, يعني, try to catch up in the any step of your investigation. So if you forget to like elicit any renal or specific renal symptom, so mention non-steroidal if it is safe for the kidney. Mention the aspiration before it coagulation profile. And if you will say intra-articular steroid, never ever mention it without saying after excluding. And since
Yes.
it's a specialist maneuver, so at that time you can say It will be done after I will refer the patient to a specialist, okay, in doing this procedure. So try always to mention the modality, especially some modalities you need to mention the prerequisite conditions before you do that maneuver of treatment or that maneuver of investigation. There are some prerequisites which should be fulfilled, like coagulation profile before aspiration and referral to a specialist, exclusion of septic before intra-articular steroid. So only those points. I hope I didn't miss anything.
No,
But
thank you. Valuable comment as usual.
the specialist referral was a very nice question mentioned by Dr. Apu. And I think in gout, it's important to know those criteria because gout is a simple case and usually it's managed in the primary care. Okay.
Yeah.
And
Okay.
yes, I remember the risky behavior and illicit drug are sometimes important in any mono articular manifestation. Okay.
Yes.
Because you need to
Yes.
exclude usually illicit drug, IV drug abuse can seed into a joint or seed into a valve or seed
Mhm.
into a disc. فيا discitis, يا infective endocarditis, يا septic arthritis. فالillicit drug is always important. And risky behavior because reactive arthritis is always recurrent and can
Mhm.
be more asymmetrical. تمام؟
Mm.
صح, is more like a fleeting arthritis, but you cannot depend on this feature. Young patient, recurrent
Mhm.
attack, you have to exclude. Okay, and I like too much when you were looking in the hidden areas because psoriasis is a trigger for gout. So really, when you examined for the tophi and the hidden areas, it was a very nice, and also lymph nodes are important. تمام. So lymph nodes, psoriasis, hidden areas, tophi, dehydration. If any renal involvement is there, look for AV fistula. At least give a look at the cubital fossa. تمام. If there is an IV drug abuser, you will pick up the needle track. If there is a renal precipitating factor, like decreased renal function, anything, you will pick up an AV fistula. And believe me, who will go to Egypt, guys, any case related to kidney, never ever miss the cubital fossa, especially if the cubital fossa is covered by a high sleeve or by a veil ولا شاول ولا يعني أي شيء محطوط على الإيد يعني. Because usually those patients will not tell you I have a kidney issue, will not tell you I'm on dialysis. I don't know why, but it happened many times in Egypt that the patient had to pick the AV fistula by himself. So whenever the kidney is a major risk factor for the condition you are handling in your scenario, please check the cubital fossa. Okay, that's it. Thank you so much. The
Okay.
cases
Thank you.
was very nice, wallahi. And
Yeah.
thank
Yeah.
you,
Both.
Dr.
Yeah. Thank you, Dr. Hind, as well. Very nice comment and informative, as usual. So the trick in this scenario, don't do aspiration before doing coagulation profile. Don't do injection or intra-articular steroid injection unless you roll out infective septic arthritis. It's two scenarios, by the way, in the communication. Patient injected steroid and the joint worse, and it was septic arthritis, and it was medical error. So remember this scenario in the communication. And also for hemoarthrosis, you have to roll out the any coagulation profile abnormality. It might, instead of managing the patient and treating him, you give him a complication, which is hemoarthrosis. For example, you are going to aspirate and he will bleed inside. He will have either hematoma or hemoarthrosis. Other comment, of course, is valuable as well. Any question before ending the session? Anyone has comment or question? Yeah, Dr. Remaz Abdul Hamid Hassan, alcohol license service. Remember the pulse, and it's a little bit similar to it. Well, patient advice license service, here alcohol license service. So remember the pulse and the name mostly related or similar, I mean, alcohol liaison service. Sorry. Any question? Thank you, Dr. Salma. Thank you, Dr. Hanadi, Dr. Ayula. Good session. It's one of the important topics, and as well, it was wonderful performance from both of you, Dr. Ayula and Dr. Hanabi. The time to end the session. See you tomorrow, inshallah, with the communication day. Thank you, everyone. And Dr. Hind, good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.